Mathieu Boniol on organizing screening for prostate cancer using the prostate-specific antigen test. Does this do more harm than good?
So, thank you. As you see, I'm going to talk about PSA test, and we've done an evaluation of whether this PSA test does produce more benefit than harm. So first of all, the first thing you want to know is, does the PSA test answer to the question you should have, which is a reduction of the mortality from prostate cancer? And for that, there has been two large multicentric trials, the PLCO, the American study, and the ERSPC study, which are both the very good quality studies, but they produce some conflicting results. They've been published in 2009, they published some update in 2013, and the conflicting result stays there. The ERSPC, the European study, found a 20% decrease in risk of prostate cancer mortality, but the PLCO study found a totally flat result. Both have several qualities and some weakness, but we cannot really answer from that which one is the correct. We don't know, so we have to live with that. And I really doubt that there will be some additional new trial to answer to this question. So in the present stage, we don't know if it works or not to decrease the mortality from prostate cancer. But what is going on in practice? This is the situation that we have in France. The slide is not that nice, but basically what you should have seen on this graph, on the y-axis, you have the frequency of use of the PSA test, and on the x-axis it was the age. I'm sorry that it doesn't display very nice, but basically what we saw in France from the data from the national insurance is that a large proportion of men are using the PSA test regularly. In our analysis, we found that for a man aged 65 years of age, more than 80% of them will have received a PSA test during a period of 3 years. So it means that we are in a situation already of generalized screening, even though if it's not organized, people are using that regularly. And most of them receive 2 tests during every 3 years. So it's a very, very big activity ongoing without the evidence from the trials. And this is what it gives as a result in terms of individual risk. Here we summarize the information about the risk of dying from prostate cancer and getting the incidence of prostate cancer if you follow men from the age of 50 to the age of 80 years. So what will be going on is, first, before the PSA test was enforced in France, for this follow-up from the age of 50 to 80 years of age, 2% of men would have died from prostate cancer. That was the situation in the 1980s. And the incidence for these men before the PSA test was 5%. 5% of men from the age of 50 to 80 would have developed a prostate cancer. So you see that less than half of them would have died of it. But that was the situation, 5%. After the PSA test was introduced in France, the incidence raised a lot. You see that it was 5% before, and it raised to 14%. The thing is that the mortality didn't really change between the two periods. So in 2000, the individual risk of dying from prostate cancer stayed at 2%. So it means that all this bulk of cancer that have been diagnosed can be, for most of them, considered as an overdiagnosis. So cancer that would have never appeared in these men. And could we dig even further? Certainly yes, because this is what we know from autopsy series. A lot of people carry what is under microscope, what is under microscope labeled as a prostate cancer. There has been autopsy series, the work from SAC, for example, showing that at the age of 70 years, about 70% of men would have under a microscope in their prostate something that would be called a prostate cancer. So there is a really big reservoir in which we can overdiagnose men, label them as prostate cancer, but these are not prostate cancer that will have conducted to a death. So what to do? We have a conflicting result about the efficacy of PSA test to decrease the prostate mortality, but PSA screening may save life if only we consider the RSPC study as right. And the question that we had is, would that then be useful in population? So we made an estimation of the benefit and harms if one would apply the PSA test like it was done in the ERSPC study. And we've not only looked at prostate cancer mortality, but we also looked at all the events from the test to the diagnosis of cancer and to the death from prostate cancer. And this is what we have. It's quite complicated figure, but I will try to explain. We consider the population of 1,000 men. On the left side, you will see the different events in the absence of screening. So in the absence of screening for these 1,000 men, if you follow them like, if you follow them, prostate cancer diagnosed for this population, and you will have, in the end, 5 prostate cancer deaths. On the right side, it's what is going on if you are applying the ERSPC study protocol. You will then see the little green box. It's very hard to see on the screen, but they do exist. It's the benefits that you would get from the screening under the hypothesis that the ERSPC study works. So basically, you see a little green box showing a decrease of the death. So you will avoid 1 death, basically. You will also avoid 1 high-risk prostate cancer. But what is impressive is the red box, which are the harm, because to gain this, to prevent this death, you have to add a substantial number of biopsies. And biopsy is not a total neutral procedure. Here you had 147 biopsies for these 1,000 men. You had a lot of new overdiagnosed prostate cancer. Here it's about 36 additional prostate cancer. And this will create over-treatment. This will create additional treatment which will create harm. And these are the harm. The harm will be additional impotence. Here it's 14 additional impotent men. It's additional incontinence. It's 3 additional incontinence. And you could also have sometimes additional fecal incontinence. Additional to that, there is also a mortality associated with the biopsy, because biopsies are sometimes associated with adverse event, with complication needing rehospitalization and sometimes infections. And there is also the side effect of radical prostatectomy, which is associated with a small proportion of death. So overall, you see that to gain 1, to prevent 1 death, you have to create a very big number of men who would have to suffer for the different side effects. So in conclusion, this is what we have. We have first conflicting result about randomized trial on whether the PSA test prevent the prostate cancer mortality. Despite this lack of evidence, there is an increased use of PSA in the population, and it generates a lot of overdiagnosis, which means diagnosis of prostate cancer in individual who would have never suffered from it if you would not have performed the PSA test. Even in the best hypothesis, if we consider that only the ERSPC study is true, then because of the number of biopsy that you have to do, of additional biopsy, because of the number of additional prostate cancer that you have to diagnose, on the balance of benefit and harm, it shows that you have to create a very substantial number of harm. And to conclude, I will just mention that in May 2013, you should have noticed that the American Urological Association, which really strongly defended the PSA screening test until very recently, they totally changed their recommendation about PSA screening, especially because of this side effect and the absence of evidence of clear evidence of the impact. And they then decided to stop recommending routine PSA tests. Thank you for your attention.
Thank you very much. You mentioned in Yes?
You know, I always find these studies quite confusing because they're about populations, not people.
Can you?
Alice Goodman with ASCO Post.
Thank you.
first of all, these are popular. This is looking at whether or not to publicly fund PSA screening.
Partly.
But for the individual man who's asymptomatic and has a very low PSA and gets a doubling of PSA and has high-risk prostate cancer after surgery, it's not helpful. Do you know what I'm saying? I think this is just more about recommendations for what insurance should pay for than rather whether an individual man should go for prostate cancer screening after a certain age.
Would you like to answer that?
Yeah, no, it's absolutely not that. It's not aimed at providing some evidence for insurance company or anything like that. It's about showing that even if we consider that the PSA test can prevent maybe one death, you will have to additional, for healthy men who would not have suffered from anything, would have not developed any symptom, you will have to create an additional burden. You will have to create some incontinence, and you will put them at risk for dying for some procedure. Because, for example, let's take the biopsy. Biopsy, to prevent one death here in the best hypothesis, you will have to create for 147 men who would not have suffered from anything. You will have to do the biopsy for them. For some of them, you will have some further hospitalization for adverse event. But basically, at the beginning, they were not asking for anything. And they might risk, there is a little risk of dying from the biopsy following these adverse events. The radical prostatectomy, it's also not something, when you have been diagnosed for prostate cancer, you see that to prevent a death, you have to add about 36 additional prostate cancer. So you put a label to 36 people who would not have suffered from anything of cancer. So at an individual level, they might feel, oh, that's very nice, I've been diagnosed thanks to the PSA test. But without the PSA test, they would not have been diagnosed, they would not have to suffer from a radical prostatectomy, and the PSA test would not have any impact. The thing is that the ultimate aim point, even at an individual level, is to prevent the death. So at an individual level, you want to know if the PSA test will really prevent the death. And for the moment, we have two trials. One is telling it doesn't change anything. Should you do a PSA test or not? And at an individual level, there is the other one that says maybe you will prevent something, but you have to generate a lot of burden.
It still doesn't answer the individual question to me, but your results are your results.
Perhaps you would like to answer or elaborate more about the men over 70, and perhaps some suggestions about men at high risk, such as those with family history or Afro-American men, perhaps we could help with.
That's a quite different situation, because here, the use of, here what I'm talking about is the massive use of PSA tests in population, which is not something that should be, in my opinion, done, because it shows that it's not helpful. But for people with an individual risk, well established, family history, and other kind of risk, maybe the PSA test is helpful for the follow-up of these people, but not as a diagnostic test itself, not as the only sole diagnostic test that should trigger the biopsy and that will trigger the surgery later on. And there is also the digital rectal examination that also works quite well. And that's a question of follow-up of individual high-risk people. But what I'm mentioning here, my focus in this work was about what should we do that for healthy men? Because in France, that's the situation. We have some healthy men coming here, and they will receive a prescription for a PSA. And maybe for these men, we are at risk of overdiagnosis and doing more harm than benefit.
Question?
Helen Saul from the European Journal of Cancer. Has the change in the American recommendations had any impact on the uptake of the test?
I don't know yet. I really don't know yet, because it's quite recent, and I've got no statistics or no figure about that. I'm pretty sure that it will, if there is a change in the use of PSA test, it will rapidly change the incidence of prostate cancer. Because as you've seen, what the PSA test did in population is to artificially increase the incidence of prostate cancer. So I'm expecting that looking at trends in incidence, maybe we'll see a decline if people stop using it.
To artificially increase the risk of low-risk prostate cancer that perhaps
of low and middle-risk prostate cancer.
Perhaps you want to mention something about other strategies, such as surveillance when we discover prostate cancer, because of this low risk?
For the surveillance of low-risk prostate cancer, maybe the PSA could still be used, but really it's really another question.
Do you have other questions?
Just what you were alluding to, which is if you have a PSA of 6, you just get surveillance now in the U.S., supposedly. Is that what you were alluding to in the U.S.?
No, I was not. I actually was alluding to those patients who have a Gleason grade of 6.
That's what I said.
Who do a Gleason grade, not a PSA of 6. That one of the strategies is to discuss with the patient and to offer them the possibility of active surveillance, which means that they are monitored very, very carefully, and they are also not just offered radical prostatectomy as had been in the past.
It's the watchful waiting.
The watchful waiting, active surveillance, but they're not waiting, they're watched. They're carefully watched. Another question?
Thank you. Sylvie Lapostole from Agence de Presse Médicale. You said that in France, 80% of the men over 65 had a PSA.
Had a PSA test within the last 3 years.
Okay. How do you explain this high level of participation comparing to the breast cancer or the colorectal cancer screening? And it's really hard to convince the people to do it. Is it just because it's easy, the first test is easy to prescribe? Or?
It's essentially because it's very easy to prescribe, and what we've seen is that basically this test is prescribed with some other biological tests. And when you have a healthy man, there is the current situation. GPs are seeing men coming in their consultation, age 50, and they say, okay, you have this, you have that, you have your cholesterol, you have your LDH. Okay, you have 50, maybe I will put a PSA test. And it's essentially the GPs who are prescribing that because it's very easy. And nobody sees the costs of it, of course. And so it's really a question of the fact that it's really an easy test.
So a blood test is easier to do than a colonoscopy, clearly. But I think the American Urologic Association has recommended discussing this with the patients carefully. They haven't recommended don't do the test.
No, of course, because they were the strongest defender of the test. So now they have turned totally their opinion about applying this test to a mass population as a general screening. But now they are recommending the discussion. I'm not sure that it will be totally efficient to change the attitude, especially in France, of having the GPs just putting an additional sentence about that.
Question in the front row? Oh, you're first, please. I'm sorry.
Helen from EJC again. Is France unusual in this level of uptake compared to other European countries?
I don't know. I don't have very good statistics about the other countries, but I'm pretty sure that in several countries you will arrive to about the same magnitude of using of PSA tests, especially because the incidence has increased a lot in several countries, the same way as in France, but it's very hard to get access to this data because you need to have access to the all insurance data.
Professor Fitzpatrick from the Irish Cancer Centre, do you have any data on this from other countries in Europe?
Yeah, in fact...
He's an eminent urologist from the Irish Cancer Centre.
Thank you. No, in fact, Mathieu is right in many ways, except that it does vary from country to country, and I'm thinking of the United Kingdom, where it's not recommended that there should be general screening. And so, in fact, the level of PSA testing in the United Kingdom is very, very low. Compared to that. I think what Mathieu has been saying also is that what you don't want to happen is for just this general screening of absolutely everybody, everybody gets tested, even people who have comorbidities that would actually prevent them from having curative treatment anyway. And I think that's really one of the big points that has come from your talk.
Thank you.
Thanks, Cora.
Thank you. We have a question in front.
Isabelle Catalan from Medscape France. Do you think that tests should be only prescribed by urologists, not GPs in France?
I really don't know if it's the best way to do. I really don't know. Really, it's a question because urologists will say, "Oh, we should be the one to conceal because we have the expertise, etc." But it's also very important to keep the patient with the normal track, seeing the GP first and discussing with all the symptoms that the patient could have in a consultation with the time that maybe a neurologist would not have.
But perhaps they should discuss the risks and harms of doing the test.
Yeah.
The GPs as well should be educated.
The GP should be educated about that, yes.
Are there any more questions? If not, I think we'll go on. Thank you very much. That was absolutely excellent.